Our speaker today is Dr. Kristine Matusiak. Dr. Matusiak is a clinical staff hematologist and assistant professor of medicine in the Division of Hematology and Thromboembolism at McMaster University. Practices mostly within Hamilton Health Sciences. She completed her subspecialty fellowship training in hemoglobinopathies. Oh, that's good. And obstetrical hematology at the University of Toronto. And her clinical interests include adult hemoglobinopathy care, women health and hematology, and care of pregnant patients with hematological issues. She recently completed her master's in medical education from Dalla Lana School of Public Health at University of Toronto. And her interest is in postgraduate medical education and interprofessional education and collaboration. Dr. Matusiak will be talking to us today about the irony, I like that one, good title, Kristine, towards equity-driven reference range for the world's most common nutritional deficiency. Without further ado, Kristine, the floor is all yours.
Thank you. So I'll start with the land acknowledgement. McMaster University recognizes and acknowledges that it is located on the traditional territories of the Matusiak and Haudenosaunee nations and within the lands protected by the Dish with One Spoon Wampum agreement. So I'm going to speak today about equity-driven reference ranges or intervals for the world's most common nutritional deficiency. Hopefully the title has given it away that I'm speaking about iron. I do have a disclosure for a consulting fee with Pfizer, but I will not be making any specific therapy recommendations in today's talk. I also want to borrow some verbiage from a great mentor and expert in this field, Dr. Schulzberg, and note that I will be using terms like women and female throughout the talk to highlight important barriers in care and knowledge gaps for equity-seeking groups with biological capacity to menstruate, become pregnant, give birth, and lactate, but acknowledge that these terms are exclusionary and these experiences may also apply to people who do not identify as women but have the anatomy to do these things. So at the end, I'd hope that you will appreciate some of the context of sex-based reference intervals for ferritin and hemoglobin. We'll discuss some of the modern evidence-based diagnostic approach to iron deficiency, and importantly, some of the updates to ferritin reporting in Ontario. And I'd like you to leave with some thoughts about advocacy for equitable screening and correction of iron deficiency and anemia. So some of the questions that guided me when I was thinking about this topic were, what is a reference interval and how is it different from a diagnostic threshold or clinical decision limit? How are these reference intervals determined and reported? And who do reference intervals serve? If they are not serving the population that's most vulnerable to a disease, what should be done about those reference intervals? I thought I'd start with a couple of cases that are not uncommon presentations to the general hematology clinic. The first is Cynthia. She's a 32-year-old lawyer, and she was referred with anemia. She's been sent into the emergency department 3 times over the last 4 years by her family physician because of panic or critical results in laboratory hemoglobin reporting. All of these emerged presentations have resulted in transfusion of red cells. And this is despite the fact that while she's fatigued, she has concerns about cognitive slowing. At no point has she experienced significant exertional symptoms or severe symptoms of anemia suggestive of acute hypoxic end organ dysfunction. She has appropriately been trialed on oral iron over the years, but has been unable to tolerate a number of preparations due to GI side effects, and she has not been prescribed intravenous iron. Cynthia, importantly, has heavy menstrual bleeding. So upon taking her history, she has menses lasting 7 days, and on 3 of those days, she needs to change her period product every 1 to 2 hours. She experiences flooding and passes large clots, and in fact will often try to work from home on those heaviest days. due to the inconvenience and time needed to attend to that. Her other bleeding history and medical history was non-contributory. So Cynthia's historical hemoglobin are here. So you can see this is a long-standing issue where she's been operating at about half capacity with hemoglobins in the 50s and 60s. That 79 is a post-transfusion value in the emerge. And while those are flagging red, alert, alert, her ferritins, which were consistently 3 over those years, don't have any red flags. The curious provider, if they so choose, would click on the toggle button next to it to find out more about reference intervals. But certainly the busy provider who's scanning for abnormal results may miss this. Roger is another patient, a 70-year-old gentleman from a group home. He has a past medical history of schizophrenia and colonic polyps. And he was referred to by his family doctor for unexplained anemia or anemia of unknown cause. And this was felt to be unexplained because he had undergone endoscopy and colonoscopy in the past year that didn't identify any lesions. He didn't report any bleeding symptoms. And while he was put on oral iron a couple of years ago, his ferritin had corrected to the normal range. So that had been stopped, but his anemia persisted. On the date of his consult, his hemoglobin was 113 and his ferritin was 13. And he had a full anemia panel and clinical history and physical exam, all of which were otherwise unremarkable. So we'll come back to them. Iron deficiency is a global public health issue, so it affects a large proportion of the world's population. It's a top cause for years lived with disability. And across the globe, the populations who are at the greatest risk for iron deficiency and anemia are those with increased demand, so young children and adolescents going through growth and development, as well as pregnant women who are experiencing very high iron and other nutritional demands. Also, those with barriers to accessing iron-rich foods, which is a significant factor in low and middle-income countries, but within our own borders is a significant factor in those in the lower quintiles of socioeconomic levels. And of course, those with chronic blood loss, predominantly women who are between menarche and menopause, although there are a number of other patient populations with chronic blood loss due to either coagulopathies or structural factors. And this isn't comprehensive. Of course, people are individuals at risk of malabsorption, as well as a number of other comorbidities that many specialists here would be familiar with, like renal disease, CHF, chronic infections or inflammatory diseases. These are also all risk factors for iron deficiency due to a number of absorption and loss issues. When you look at the risk factors for iron deficiency, it's clearly a condition of equity deserving groups. So we've covered a little bit of that already, but certainly female sex, pregnancy, heavy menstrual bleeding all contribute significantly to the high rates among women of reproductive age. Access to high quality food, as well as high quality healthcare, period care, gynecologic care are also significant factors. And race and ethnic minorities are also considered factors or groups that are disadvantaged disproportionately by anemia. Non-anemic iron deficiency and iron deficiency anemia exist on a spectrum, but they are separate entities. Both are risk factors for a number of morbidities and mortality. Very concerningly, this being predominantly a problem of women in their reproductive years, there are significant quality of life, productivity, and cognitive impacts that impact that overall quality of life or disability rating. And if you look to the right, iron deficiency, even without anemia, has a number of presentations which may overlap with other medical conditions, but certainly should be flagged as potential representations of iron deficiency, even in your non-anemic patients. Iron deficiency is quite correctable. So oral and intravenous iron are commonly employed. Oral iron can be very inexpensive, as low as 10 cents per day. with a number of formulations covered on the Ontario drug benefit and also being available over the counter. And intravenous iron is certainly modern preparations are quite safe, have evidence across a number of patient groups, including pregnancy, renal disease, heart failure. And access to intravenous iron does vary based on location as well as coverage schemes. Why is this still such a big problem? This could be an entire talk in and of itself, but today I want to focus on lack of consensus and clarity in recognizing iron deficiency and anemia. So certainly the underappreciation for the clinical relevance of iron deficiency without anemia, the variable clinical diagnostic limits, no clear consensus, particularly for equity deserving groups, and discrepancies between clinical diagnostic guidelines and laboratory reporting of ferritin reference intervals, as well as hemoglobin. So what is a reference interval versus a diagnostic threshold? A reference interval is typically laboratory generated, both from the manufacturers of common assays, but also the labs that are employing those assays. A reference interval is meant to be at the highest standard derived from a reference population that is free from the disease in question. So this should serve as a control group. They should not have risk factors or evidence of the disease that you are trying to rule in or out or identify with a reference interval. And many of us would be familiar that most reference intervals are generated to give us a range where 95% of the normal healthy population should fall. So of course, 5% of the normal healthy population will fall outside of that reference range as well. Clinical decision limits or diagnostic thresholds differ in that they are meant to be typically evidence-based recommendations to discriminate between health and disease state and thresholds at which you may employ an intervention. And certainly in this talk, we'll be speaking about how these are often, these may be discordant, certainly in this case, and you may think about other items that you're measuring or following in your patient population where this may also be the case. The gold standard for iron deficiency or iron status is to do a bone marrow biopsy and use Prussian blue stain to identify iron stores in the marrow. And unsurprisingly, this is not an acceptable test for most patients or providers. It is invasive, it is time consuming, it is resource intensive. So we have long used a serum ferritin as an acceptable surrogate for measure of iron status. And ferritin is a storage protein for iron. A serum ferritin concentration of under 30 micrograms per liter does have a high specificity and sensitivity and is generally accepted, certainly for those of us who are McMaster trained and know the landmark paper by Dr. Guyot that looked at bone marrow iron stores. So this is often accepted for diagnosis of iron deficiency. Although really is it when we look at ferritin thresholds recommended in clinical guidelines across the board, in the general population, there is quite a wide variation of accepted lower limits of normal or thresholds for diagnosis, ranging from 15 to 50 micrograms per liter. Pardon me, that says milligrams, but should be micrograms. And importantly, serum ferritin is influenced by other factors beyond iron status. And so there are recommendations for clinical diagnostic thresholds that may be higher in the setting of some of these comorbidities, as well as employing a more fulsome iron index, including a transferrin saturation to help delineate iron deficiency in those where ferritin may be falsely elevated or elevated due to other factors. As a result of some of the discrepancies for ferritin clinical decision limits, primarily local group of providers from across specialties, so many from Toronto and some from here at McMaster, got together to employ a modified Delphi approach to come to a consensus for screening and identification of ferritin reference ranges, or pardon me, ferritin clinical decision limits for the diagnosis of iron deficiency in the general healthy non-comorbid population, but also the comorbid population and those who have symptoms or signs of iron deficiency. So you can see here that 30, again, was where we landed, but the transferrin saturation comes in both in the healthy population, but certainly in those with evidence of or symptoms of iron deficiency, those who have comorbidities, the ferritin has a more permissible threshold of 100 if the transferrin saturation is under 20% or 0.20. This is also sometimes reported as the iron saturation, just FYI, in community labs. And they also provided some simple guidelines for initiation of therapy as well as monitoring for response. So goals for ferritin or transferrin saturation in those who you are treating. Nonetheless, there are some questions about whether that 30 is enough. So while that is based on our gold standard bone marrow studies, a serum ferritin of 50 has also been questioned as a better physiologic threshold of iron deficiency based on a couple of findings. One is that clinical trials using intravenous iron to manage iron deficiency found that 50 was a threshold at which fatigue was significantly reduced. Study using radioisotope or labeled iron found that gastrointestinal absorption of iron returned to baseline or at kind of a homeostatic level at a ferritin of 50, and that other biochemical surrogates of iron deficiency, such as the soluble transferrin receptor and hepcidin, normalized at this level of 50. So this is a question not yet employed in many clinical guidelines, but certainly should be considered in some of the most at-risk groups. So how does this translate, or what do we do when we're looking at these reports or results that are coming into our inbox? There is a huge variation of the lower limit of normal of ferritin in North American laboratories. Even though many of these laboratories use one of 4 to 5 common assays, what is consistent is that the discrepancy between female and male lower limits of normal ferritin is lower across all of the labs reporting. And this results or suggests that the identification of iron deficiency will vary significantly depending on which lab you're using and which threshold they're using to flag the result. So these are some that you may be familiar with. Until recently, this would have been what you've seen when you, getting Life Labs or Dynacare reports, so lower limits of normal of 15 or 12. And alarmingly, even those of us who have recently gone through the process of studying for the Royal College have been set up for failure in a sense, being provided with normal value tables that report a lower limit of normal of ferritin of 20 for the Royal College, of 11 for females in the Medical Council of Canada, and a lower limit of normal of 24 for males. So this systematic review looked at specifically studies reporting ferritin reference intervals in healthy adults. They also used gray literature from the assay derivations themselves. And among the 5 most commonly used ferritin assays, none explicitly excluded individuals with iron deficiency risk factors, nor did they adhere to basic clinical and laboratory standards for establishing reference intervals. So what they found in this review is that the lower limit of normal median was 8 for female individuals and 27 for males. So most of the studies, as well as reagent kit reported derivations, were far below what most would consider an acceptable clinical threshold limit of 30. So the reference intervals appear to be at a very high risk of bias due to inappropriate selection of the reference population. And current modern ferritin reference intervals historically have not been useful to guide clinical decisions, which can be very confusing for the busy clinician or those without expertise in iron deficiency. So the recommendation moving forward has been to use an evidence-based clinical decision limit, and we'll get to that shortly. We can't really talk about iron without talking about hemoglobin and anemia. Hemoglobin thresholds according to biological sex are equivalent for men and women until menarche, you can see here, at which point they diverge with a cutoff of 120 grams per liter for women and 130 grams per liter for men. This is a WHO definition. That's this divergence in the reproductive years. And then you can see at menopause, these come back together. These WHO definitions were adopted almost 60 years ago based on 4 published references and 1 set of unpublished observations, only a minority of which addressed sex differences and risk factors for anemia. Interestingly, one of the studies actually provided iron to patients in their reference population, and the female lower limit of normal rose to over 130 grams per liter, but this was not included in the WHO guideline or derivation of these suggested thresholds. Over the years, we've questioned whether there are physiologic reasons for this discrepancy in hemoglobin. And there have been some hypotheses about whether there should be a difference in erythropoietin observed, if this was pathological rather than physiological. There have been postulations that females have increased tissue oxygen uptake, but none of these have been consistently substantiated. I think taking a step back and not getting into the weeds of all the steps in erythropoiesis, the question for me is, why would there be a physiologic decline in hemoglobin and oxygen carrying capacity at the time in a female life during which there is the highest metabolic demand? So puberty, young adulthood, pregnancy, and lactation. And this is not observed in our animal kingdom counterparts. Oops, I seem to be frozen. Oh, there we go, sorry. Of course, sex hormones have been looked at in playing a role here, and there is, of course, a role in erythropoiesis between estrogens and androgens. Estrogen supplementation in transgender women, for example, seems to lower the mean hemoglobin, but the baseline remains in a healthy range above 130 grams per liter, which is more in keeping with a cisgender reference range. And while testosterone is known to impact the upper limit of hemoglobin with observations of erythrocytosis and driving hematocrit up, there does not seem to be any consistent signal that it should drive up the lower limit of normal. So sex hormones don't adequately explain this difference. Iron deficiency makes the most sense here. So it appears to be the predominant driver of sex differences in hemoglobin during these reproductive years. And looking at non-pregnant women in large-scale data in the US, if you use a ferritin threshold of 25, 38% of these women are considered iron deficient. If you use a more stringent or suggested threshold of under 50, 3/4 of US women in that premenopausal zone are iron deficient. So this seems to be the main explanation for this difference in those reproductive years. So this study did the hard work that many of these labs have not done, and they tried to generate hemoglobin distributions that were much stricter. So they did what many of the labs will have done, which was excluding adults based on self-reported health. So self-reported lack of medical history of anemia, malignancy, pregnancy, smoking, liver, kidney, heart disease, versus actually finding objective data for these individuals to exclude those with things like iron deficiency, inflammation, evidence of chronic disease, red blood cell or hemoglobin disorders. And so what they found is that when they apply the strict objective criteria to create a truly healthy population, not only do both females and males enjoy a boost in the lower limit of normal of hemoglobin, but it significantly decreases the gap between female and male individuals. And this is seen at the greatest degree in this premenopausal female population who see a jump in the lower limit of normal of hemoglobin from 103 to 124 if they are truly represented as a healthy, non-iron deficient population. And looking at a number of these kind of large population studies, as well as some smaller studies, the sex differential in hemoglobin really does not seem to serve women. It does not appear to be physiologic. It appears to be pathologic in most cases. This is a nice summary from one of the lovely RPTH illustrated guides on sex differences in equity in hemostasis and thrombosis. So they examined some of the thresholds for disease, morbidity, mortality in some of these large population studies that were not directed specifically at anemia, and found that women typically do seem to be coming up short when a threshold of under 120, 125, 130 is used. And at the lowest ranges, say a hemoglobin of 110 or less, women are disproportionately affected with outcomes like mortality. In the perioperative setting, females with a hemoglobin of 120, which is felt to be the lower limit threshold by the WHO, are twice as likely as males at their lower limit threshold to experience postoperative blood transfusions. And this was a really cool machine learning AI study done in a vascular surgery population that found that female and male patients with the same hemoglobin undergoing same surgery with who are otherwise matched have worse outcomes. And really to see that the outcomes come up level, female patients need a hemoglobin 13 grams per liter higher than male counterparts who are matched. So this is a really nice demonstration of equity rather than equality. In some other, I mentioned this earlier in that study that the WHO derived their recommendations from, but in a number of other cases, iron replacement in otherwise healthy and even non-anemic women by usual definitions will often see a positive response with rise in hemoglobin with iron supplementation, whereas men do not, and a disappearance of values below 130 grams per liter. I'll mention also that race-based hemoglobin reference ranges have existed for a long time. They, in some cases, are still reported, and some of you may have examples in your own areas of specialty, things like GFR, PFTs, where race-based reference intervals have been reported. And again, these have been demonstrated to continue to disadvantage individuals who are already at higher risk of mortality. So why would a Black woman be at a hemoglobin 20 grams per liter less than a white man? And what is the physiologic explanation for that? These are not seen as much, but they're often mentioned in literature. And there's good evidence that there are associations with poorer standard of care for these patients based on hemoglobin thresholds across a number of populations, including in the pregnant population and those with renal disease, and for the identification and management of anemia itself. And there are some race or ethnicity associated hemoglobin conditions that may result in a lower hemoglobin in individuals. So race and ethnicity should appropriately be considered when evaluating anemia, but there is not a justified biologic reason why a hemoglobin reference range should vary by race or ethnicity, because these are social constructs. I have to mention anemia in pregnancy because this is an area of interest for me. Again, the WHO defines anemia for this population as a hemoglobin of less than 110 in the first and third trimesters, or 105 in the second trimester. By these types of definitions, about a quarter of pregnant women are considered anemic, and the vast majority are due to iron deficiency. And iron deficiency risk increases progressively through pregnancy due to the demands of pregnancy. A pregnancy requires an additional 1,000 milligrams of iron on top of baseline levels for women. And again, in the pregnant population, iron deficiency and anemia disproportionately affect pregnant people of lower socioeconomic status and racialized individuals. And this happens at multiple levels, including lower rates of screening despite higher prevalence, higher prevalence when we actually screen. And despite identifying patients with iron deficiency and iron deficiency anemia, patients who are racialized or are from the lowest quintiles of socioeconomic status do not receive appropriate therapy at the same rates as their white and wealthier counterparts. And anemia is associated with a number of adverse perinatal outcomes at the level of the mother, placental abruption, postpartum hemorrhage, transfusion, and severe maternal morbidity and mortality are all associated with iron deficiency and anemia. For the fetus and neonate, preterm birth and low birth weight, as well as a number of neurocognitive disorders have been associated with iron and iron deficiency. Of course, there has not been any clear causal nature here, but certainly iron deficiency and anemia should at the very least flag high-risk pregnancies. And of course, when you're considering the patient in front of you, typically a working person who's contributing to society, who may or may not have other children or family members they're taking care of, iron deficiency and pregnancy is associated with fatigue, weakness, dizziness, issues around stamina and cognition, and dyspnea. These are all things that happen in pregnancy anyways, and so often these can be mistaken as regular old pregnancy symptoms rather than signs of iron deficiency. So similarly, this is going to be presented at the American Conference, Society of Hematology Conference in just a couple of weeks. The same group from Toronto did a systematic review of studies defining hemoglobin reference intervals and normal values in healthy, quote unquote, pregnancies, evaluating whether they adhered to established guidelines for deriving reference intervals, as well as whether or not they did any kind of assessment for ferritin and B12 levels or risk factors for deficiencies in their reference population. And this was pretty disappointing, of course. So over half of the studies did not adhere to the guidelines for deriving reference intervals. Most did not identify whether individuals even had a risk factor for iron deficiency, but even more concerning, 91% didn't exclude those with overt laboratory evidence of iron deficiency when they were deriving hemoglobin reference ranges, and similar numbers for B12 deficiency. So if you recall that WHO lower limit of normal for hemoglobin is 110 at term, in pregnant patients treated with oral and intravenous iron in pregnancy, who were enrolled with moderate anemia, so enrolled usually in the first or early second trimester with hemoglobins of 110, so or slightly less, so just below that reference range. When those patients were adequately treated and assumingly treated to the point of iron repletion with a combination of oral and IV iron, actually normalized their hemoglobin at term, which is, if you look at even our OB population here, it's just not that common to see a pregnant patient with a hemoglobin of 125 at the time of delivery. Or certainly we are far too accepting of patients who have hemoglobins far below that. So again, the current reference intervals likely do not represent a healthy pregnancy population, and we are therefore missing opportunities to identify and address iron deficiency in pregnant individuals. So these inaccurate reference intervals disproportionately impact those who are most vulnerable. The common reference intervals for ferritin have led to underdiagnosis, undertreatment of iron deficiency, and of course, this disproportionately impacts those who are already at risk. And unchecked, this feeds into a cycle of non-physiologically based sex-specific indices for ferritin and hemoglobin because we are not appropriately deriving reference intervals from healthy population. It's kind of hard to find a healthy population. This also is fed into under-recognition, missed or delayed diagnosis of issues of bleeding disorders, gynecologic issues, which are the predominant contributors to iron deficiency in the reproductive population of women. So I liked this quote from Dr. Scholesberg in one of her recent publications about this issue that really, I think, puts it in black and white. Being a woman and having this is non-anemic iron deficiency or iron deficiency is not normal. Being a woman and having iron deficiency anemia is not normal. Being a Black woman, Indigenous woman, or woman of color and having non-anemic iron deficiency or iron deficiency is not normal. And this really should be our beacon or our guiding thought when moving forward with reference intervals and diagnostic cutoffs. The good news is that Dr. Scholzberg and colleagues, including the wonderful Dr. Pai, have been working on generating this evidence over a number of years, working on that Delphi statement, and have enacted policy now at the Ontario lab medicine level to roll out clinical decision limits for ferritin using a threshold of 30 micrograms per liter. And this, as of September, is now appearing in the community lab reporting for Life Labs, Dynacare, and other community lab partners. So this is the information that is now provided for providers who are interpreting ferritins. Not only are they getting a bit of granularity about who may or may not be considered iron deficient, they also have some access to information on further information about diagnosis and treatment. And really, that's not an understatement to say that this will change lives. There are so many busy providers who rely on those flags, those clinical decision limits to notify us or to pique our interest or attention that something is awry. And having a flag on evidence-based lower limits of ferritin will certainly impact a large portion of our population, particularly those who are working population of women. So how can we continue to move forward towards equity-driven and evidence-based solutions? I think I really want to emphasize this is really everybody's problem. It impacts many of our patient populations, regardless of their comorbidities, and collective action is really needed. So we need to continue educating ourselves about symptoms of iron deficiency and anemia, and particularly iron deficiency without anemia. We need to look at our own patient populations and think about those who are at greater risk, and think about the systemic inequities to care that those patients may be facing, and to continue asking questions about the distinction of reference intervals and clinical decision limits beyond ferritin and hemoglobin, and maybe this is applicable to other areas of your practice. We need to keep working towards evidence-based reference ranges. There is that question of should we be moving up to 50? And I think we need to keep asking those questions and asking for evidence-based screening programs for iron deficiency, particularly for at-risk populations. Really, to date, there is no consistent screening guideline for iron deficiency in reproductive age women. And I do question whether we should have that flag in EPIC. If you open that tab now, it has that information about the clinical decision limit of 30, but if you don't notice a red mark, will you open the flag? We need to continue advocating for equitable access to some of the care issues that predispose individuals to iron deficiency and anemia. So issues around period poverty, reproductive health, gynecologic care, especially in a day and age where much of that is being dismantled elsewhere. And we need to advocate for equitable access to therapies, not only iron therapies, but therapies for heavy menstrual bleeding or other for accurate and timely diagnosis of bleeding disorders, and access to pharmacologic therapies, both within the hospital setting and in the community. So what can you do today? Apply that high index of suspicion, because in that reproductive age woman sitting in front of you, there is a very high chance that there is an element of iron deficiency, whether or not that is the primary reason that she's seeing you. Apply those modern clinical thresholds for ferritin, and certainly the reference intervals or clinical decision limits are helpful, but do not wait for anemia to diagnose and treat iron deficiency. And we have excellent local resources to learn more and to share. So the Heme Equity website, which is is the basis for this move at the Ontario Laboratory Medicine Program, and has a lot of information about diagnosis and management. And of course, want to plug that we are extremely fortunate at this time in our area to have access that is quite equitable for intravenous iron that can be ordered by any specialty family doctor or NP. And that is very much thanks to the work of Dr. Zeller, who established that program in our region. And we should continue to advocate for its existence. So I wanted to come back to Cynthia and Roger. So Cynthia is now practicing law at double the hemoglobin. I did use the HNHB iron infusion pathway I just mentioned to access intravenous iron due to her history of poor tolerance of oral iron. And she has been able to sustain a hemoglobin in the quote unquote normal range, but still fighting with the ferritin. She has ongoing heavy menstrual losses. She is working with gynecology and considering options to address her heavy menstrual bleeding. So she is somebody who's not a one and done, definitely needs ongoing care. And I struggle to keep her ferritin above 50, despite the fact that I have normalized her hemoglobin. But it's very much my goal to make sure that she remains iron replete and not just free of anemia. Roger, on the other hand, I think probably had long-standing undertreated iron deficiency, probably as a result of the history of polyps. He definitely had a history of bleeding in the past. He was, not to anyone's fault, but undertreated because when his family physician started oral iron several years ago and saw his ferritin normalize into the 20s, he stopped it, and Roger remained iron deficient for many years, although fortunately didn't have any significant declines. But with oral iron, which he tolerated very well, he was able to correct his anemia and has maintained this for over 6 months now that he's discontinued therapy, which suggests that he doesn't have any ongoing losses. He was just kind of in the hole and needed help getting out. That's it. So thank you for your attention. I'm happy to take any questions.
Thank you so much, Dr. Matusiak, for this very insightful rounds and the review of the evidence. I'm still thinking, that how many times we made mistakes, by telling a woman that that's your normal, it's okay, you're menstruating or you're pregnant and that's why you're low anemic or your ferritin is low. It's like I probably made the same mistake a few weeks ago talking to one of my daughters about that, which is I probably got to call her after this rounds to correct myself. If you have a question, please text it in the Q&A. And if you want to speak your question, please raise your hand. I have Dr. Holbrook. I'll allow Dr. Holbrook to speak, and please go ahead.
Thank you. Thanks, Kristine. That was excellent. Very clear, very evidence-based, and a bunch of pearls there around, how we set diagnostic standards. I wondered if our population of the inpatient internal medicine, there's always this question of inflammation, and I find it as equally confusing as all the other areas that you mentioned. Would you mind outlining what our approach should be to diagnosing real iron deficiency in patients with, in quotes, inflammation, which I find overly general? Could all of our internal inpatients be inflamed, in quotes, or should we be thinking of very specific pathologies?
Yeah, I think it's something that even, we struggle with when we're consulting on these patients, because there is, I'd say, a breadth of comorbidities that can result in an elevated ferritin with or without a lower iron saturation. And inflammation is certainly one of them. Your patient with your CRP in the 200s who has an active infection, that's kind of a little bit simpler, but the patients with diabetes, who maybe aren't very well controlled, the patients with renal impairment, the patients with CHF, there is good evidence around iron use in those patients now. The transferrin saturation is quite helpful. It's ideal if that's done fasting. It's ideal if that's done prior to the patient being put on iron or prior to the patient having a blood transfusion. Those can be very difficult to interpret once some of those interventions have been applied. I think I don't think any of us can really agree on a threshold of a ferritin that's too high to consider iron deficiency. I'd say my comfort zone would be if the transferrin saturation is, truly under 20, and the patient doesn't have an active bacteremia or something where I'm really concerned about giving them iron. I'm accepting of ferritins in the hundreds, probably not above 500 or in the thousands. But I think if the clinical picture fits, and certainly you can see the patients who are otherwise disadvantaged have risk factors for iron deficiency among their other comorbidities, that would be the patient I'm more primed to consider treating. But you can also see this like iron restricted erythropoiesis that can have that picture. You're really sick ICU patient, sometimes can have that transferrin saturation in the teens and their ferritins in the 2000s, and they're on pressors, they're on multiple antimicrobials, they've been bacteremic. That's the patient where I usually would sit tight and reserve iron for maybe repeating those indices when they're a bit more well, and reserving iron therapy when they're a bit more stable, because usually iron deficiency or iron restricted erythropoiesis is not the driver of their acute illness. It's usually more of a consequence. That's a very wishy-washy statement, but hopefully that's helpful.
Well, I think the ones with the really high ferritin becomes more complicated. So I thank you, Kristine, for mentioning the 500 and 1,000. I thought the 1,000 would never happen with iron deficiency, but it sounds like if your iron saturation is lower, then it's possible still, right?
Yeah, I think always worth reassessing when they're not, their CRP isn't 300, because that's probably more the driver of that restricted erythropoiesis rather than the a real iron deficiency itself. It's the impaired use of iron.
Amazing. A few questions. Can you please comment on your thoughts about the pre-op iron IV, iron infusion, and the pre-op hemoglobin goals?
Yeah, there's a beautiful CMAJ paper by Dr. Yulia Lin and Dr. Matt Chung, and I might be missing some people, but in the last couple of years, which has very concise points on how to approach perioperative anemia or perioperative hemoglobin optimization. And they advocate for a hemoglobin of 130 grams per liter across the board because of what I mentioned, where that in perioperative studies, women who are treated or permissively allowed to have a hemoglobin of 120, which we would consider normal, actually have worse outcomes. And this is probably because perioperative blood loss disproportionately affects those with lower blood volumes. So there is advocacy to aim for that 130, and they have some provisions about, time to surgery, elective versus urgent surgery, and employing oral versus intravenous iron. And then even in some cases, particularly people who are expected to have impaired responses to iron, or those who are not accepting of blood products, where erythropoietin stimulating agents are also used. And of course, we try to optimize other hemogenic nutritional indices like B12 and folic acid as well. But that CMAJ paper is really nice. It's one of those, I think, 5 things you need to know about. So kind of a quick 5-minute read.
Great, thank you. Question about why, this is a good one. Why is iron deficiency so endemic in population? I mean, excluding pregnant people, why do we have so much of iron deficiency?
Where was Darwin in correcting this?
People.
That's a great question. I think it's hard to know what these numbers looked like pre-industrial era, and our changes in diet. Certainly, there is likely a component of the changes in timing of menarche and menopause, the number of pregnancies that limit how much menstruation women have. There is a longer period of reproductive age because of earlier menarche and often later menopause. I think those are some of the postulated theories. I'm not sure where Darwin came into correcting this.
All right, maybe Mitch have more comments about that. If you want to come in and speak them up. Otherwise, we'll move on. So the other question is about elevated ferritin levels associated with NAFLD. I'm assuming also other liver diseases and iron deficiency. And should we be basing our diagnosis on ordering additional diagnostic tests for iron deficiency?
Yeah, I think anybody with liver disease would fall into that kind of right side of that diagram from that Delphi consensus, where a full iron panel is a bit more helpful in those patients. Certainly, more severe liver disease patients can have elevated iron saturations and can actually have iron loading separately outside of things like hemochromatosis. So they can be more difficult to interpret. That being said, I certainly have patients in my general hematology clinic who have maybe milder liver disease or even cirrhosis who are iron deficient once I have seen kind of their full panel. And, certainly patients with cirrhosis are at risk of things like iron deficiency due to GI bleeding, due to intake if they have ascites and impaired appetite. So they are definitely not exempt from iron deficiency. But the full panel, including transferrin saturation, is usually a little bit more helpful.
Excellent. Question about bariatric surgery. So this Dr. Daboni, she sees a lot of those, should post-bariatric surgery patient go straight to IV iron? She shared her experience that oral iron does not work. And can you comment on liposomal iron?
Yeah, that's a great question. I wish I knew the evidence a little bit better around bariatric surgery, but certainly common sense would tell you that oral iron may be more challenging in those patients. I think there is evidence that the bariatric surgery population already goes into surgery iron deficient, predominantly women, and obesity is a risk factor for iron. So should we go straight to IV iron? I don't know if there's evidence to tell us that, but I think maybe we are a little bit too lax with our trials of oral iron, meaning either we are not really truly assessing adherence and tolerance, or we let it go on too long despite intolerance or ineffectiveness. And so I think if you're starting somebody on oral iron, assessing for an increment in their hemoglobin, an increment in their ferritin in, I'd say, 4 to 6 weeks, especially in a high-risk population. If at that point they are unable to tolerate, maybe consider an alternative oral iron therapy. If they're not showing incrementation despite appropriate adherence, then I think moving to IV iron would be my next move. And we are very lucky to have pretty good access to it in the community. So we are much less tied down by some of the financial and coverage barriers that other LINs or regions face. And I don't have a lot of experience with liposomal iron, and I definitely don't know any evidence about liposomal iron in bariatric surgery. Sorry, Dr. Taboni.
Thank you, Kristine. I don't see more questions. I'm going to give opportunity for people to type their questions or raise their hand if they we still have a few minutes. But honestly, Kristine, listening to your talk, just like, oh my God, how did I not even think that this is an important issue before, right? And I do see a lot of patients with iron deficiency anemia. In your work or into this grand rounds or interest in equitable reference intervals, let's call them, what's the next one, right? I mean, we've learned that race-based reference intervals are flawed and there's no biological basis to them. We think that gender-based may have some evidence to them, but now you're teaching us that diagnostic of the shoulder are actually not much different. Which is the next number we need to look at? Which is the next topic in lab medicine we need to look at that you might have come across to ensure that we continue to provide equitable care or to start, I should say, providing equitable care in some areas?
In hematology, it's neutropenia and neutrophil counts, and the exclusion of diverse populations in the derivation of neutrophil reference intervals, leading to over-investigation and sometimes treatment deviations of patients with neutrophil counts that are below the reference interval, but are clinically benign. So this used to be called benign ethnic neutropenia. Now we have better information about its origin, which is a Duffy null, or lack of a certain red blood cell antigen associated neutrophil count seen in a proportion of the population with African or Middle Eastern ethnic heritage. So the number of patients we see or get referrals for in our clinics is actually quite large. And most of the time, these are healthy patients who have never experienced any infections. They sometimes end up having quite extensive investigations. And I think in the most concerning cases, things like therapies are withheld or changed because of a neutrophil count of 1.1 in this patient who's had a neutrophil count of 1.1 for their entire life. So I've had patients who've had their thyroid medications, particularly around things like Graves' disease, adjusted. And of course, things like chemotherapies can be dose reduced in those patients, probably inappropriately or unnecessarily, I should say, because of course they understand the fears. But I think that's another one that's come to light in the last few years that needs a bit of attention or education.
I think we need one of your colleagues to give us another grand round on that one. I want to learn more about. We have Dr. Sidhu hands up. Mona, you can go ahead, please.
Thank you for a great presentation, very informative and evidence-based. I just had maybe a comment more than a question. It may be like a personal story. Being pregnant, I had the non-anemic iron deficiency. It was quite profound, didn't respond to oral iron. I had to advocate strongly to receive IV iron. Now, 2 years postpartum, still quite iron deficient, but I can't advocate to the same degree because the limitation is that the family doctor doesn't have hospital privileges, and therefore I can't, I take oral iron, I don't know what, and they say that, okay, I will refer to a hematologist. They say that based on your blood work, you don't really qualify to see heme. And so then I'm stuck. And now I'm like, okay, I guess I will chronically live in the 20s, a ferritin of 20s forever, and take ferrous fumarate 3 times a week. And then that's kind of how I live now. How do we navigate other people like me?
Yeah, this is a terribly common scenario. I was in the same scenario. I didn't talk a lot about, relative anemia and, anemia within the reference range, but, my experience of having my iron corrected in pregnancy, it took my hemoglobin from 115 to 141. So, I was anemic relative to my baseline and certainly was experiencing the symptoms of iron deficiency and that relative anemia. If you do live in our LIN, your family doctor can order intravenous iron, but there is definitely a lot of historic discomfort around intravenous iron, and certainly the older formulations had more side effects. There is a myth or a misunderstanding that IV iron is reserved for severe anemia or certain cutoffs. I do not practice that way. If a patient has had an adequate trial of oral iron and cannot take it for whatever reason, even if they are not anemic, I'm quite comfortable correcting their iron using IV iron.
Thank you.
I mean, it's a bit disheartening to know that our colleagues struggle with this. Imagine what the population is, the layperson, the one who's not within the healthcare system is going through. And I would appreciate that we have much easier use of IV iron in our area right now, knowing that growing through the years, seeing how difficult it was to get an IV iron at one time, how easy it is right now. And I've seen even patients were able to, with iron deficiency without anemia, actually for their symptoms, able to get done. So it's interesting that that knowledge has not translated to the community. The other part, Kristine, is how do we now start educating the public? Right, because again, I told you, I've misinformed my young daughter, young woman daughter, into this, So how do we inform the public that this is the new thing, So is there any campaign going on around that? Understand that you and your colleagues are like leaders in this area.
Yeah, part of the rollout of these reference interval changes through the lab medicine program has included, that information and referral to that Heme Equity website, which has very kind of simple evidence-based information for patients and providers about how to recognize, diagnose, and treat iron deficiency. So, part of that's been a media rollout, but there are also links to it in the information provided on the reference or the clinical decision limits, I should say, that are now reported from those labs. So they should actually be able to see those websites and roll it out. But definitely ongoing education, adjustment of those reference intervals for our exam standards, education in postgraduate medical education. These are all the layers that need to be addressed to kind of dismantle this systemic issue.
Amazing. Dr. Matusiak, thank you so much for an exemplary grand rounds. Honestly, from the topic to the content to the way you delivered it, it's fantastic. Great discussion. Thank you very much, and wish everyone the rest of your day, good rest of your day, and we'll see you next week.
Thanks for having me.